Hi, folks. Yeah, it's my pleasure to get to introduce our first keynote speaker today, Dr. Nathan Lachowsky. Many of you already know Nathan, so I apologize for this additional introduction. Nathan Lachowsky is Research Director at CBRC and Principal Investigator of the Sex Now survey. He is also an Assistant Professor in the School of Public Health and Social Policy and Michael Smith Foundation for Health Research Scholar at the University of Victoria. Championing interdisciplinary and community-based approaches, he has conducted HIV and sexual health research with sexual and gender minoritized men, including Indigenous, Two-Spirit, and ethno-racial minority men across Canada and New Zealand. Nathan's principal area of research focuses on social and behavioral epidemiology, and the importance of developing and analyzing mixed methods data to inform public health practice, health service provision, and policy. He conducts interdisciplinary research within a social justice framework in order to achieve health equity for marginalized communities. So please join me in welcoming Nathan Lachowsky.
Good morning. Good morning after Halloween. This is my professor look. I'd like to start with an acknowledgement of the territories, the Musqueam, the Squamish, and the Tsleil-Waututh people for the lands and the waters that they've protected and taken care of for generations. For me, as Research Director at CBRC and as part of the overall organization's work on reconciliation, it's been very important for us to think about what does it mean to do a survey with broad cross-sections of our community. And if folks would have seen yesterday morning, Harlan Pruden talked a little bit about the Two-Spirit Dry Lab, which is one of the kind of innovative ways that we're thinking about and trying to work towards better models of doing this kind of work. I also think a lot about the time, the generous time that many elders and Indigenous leaders have provided to those of us on the team, myself included, around teachings in research. And one in particular that I think a lot about is balance. We've often had a very deficits-based approach to work with our communities, and thinking about how we balance some of the information that we ask about and collect, I think is incredibly important. So I'm going to try and do that a little bit today as I talk through what's been going on with our program. So I'm going to talk a little bit about some of the high-level findings from Sex Now 2018. For folks who have been around the conference yesterday, you'll have seen there's several other people who have been talking and working about the data. This is very much as a collaborative project, and hopefully, if nothing else, we might entice you to think about also wanting to work a little bit more with the information we have. I'm going to also talk about a project that Kiffer Card, who's a postdoctoral fellow working with us, has been leading, which is called RStats, which is a data visualization tool meant to really try and work on democratizing access to the data that we've got. I'll talk a little bit about Sex Now 2019, and as well as 2020 and beyond. And then I'm going to try and leave some time for questions. So this is my commitment to you that I will finish so that we have time for questions. And hopefully Ben can help me with that, because you know I love a microphone. Okay, so I need to really start by positioning Sex Now as a highly collaborative effort. Oftentimes it gets talked about as CBRC's flagship research project, but really it comes about through a collaboration with a variety of partners across the country. I think the idea of trying to do a national community-based research study is quite bold, and it really is about the boots on the ground, the people in the community that are across this country that really help shape what this looks like. This includes everyone organizing all the different events and tables to do collection at Pride events. When I think about the work that we did in Winnipeg, going to a Two-Spirit powwow, all of that is really possible through other people that are not me. So I feel very much grateful to be able to stand up here and share a little bit with you, but really this is a much broader team effort. Also, for 2018, we collaborated with the HIV Reference Services Lab in Winnipeg through the Public Health Agency of Canada. They're the folks that do all of the testing for dry blood spots as part of HIV surveillance in Canada. And so for us, that was a really opportune partnership because they were keen to support the work that we were doing, really interested in some of the values that we were putting forward in terms of the survey, and also provided all of the supplies and testing in kind. So those are good friends to have. So Some of you guys will have seen these slides already, and so I won't talk too much about them. But basically, Sex Now went back to its roots, doing a paper survey. So this is where we started in the early 2000s, going out into the community with a clipboard and a pen and asking folks if they'd do a survey. There's something really magical about going and spending that time in person, where you actually get to meet the people face to face, get confronted with some of the concerns and questions and critiques that people have in community about who are you, why are you doing this, how is this data going to be used, where is this going to go, and all of those things. So I think that was a really awesome opportunity. We learned a lot about doing an in-person survey in high-intensity environments like Pride. And people had the option to give a dry blood spot in addition to doing the survey. We were collecting from Winnipeg Pride to Calgary Pride across 3 months in the summer. And folks had to be living in Canada, at least 15 years of age, 18 if they were doing a dry blood spot. And they could either identify as part of the community or have had sex with another man in the past 5 years. So we tried to give some flexibility there in terms of entry. So our distribution really matches where we went to in terms of provinces. And one of the things that I'm excited about is that we got some data from places where we really haven't had good data before on our communities. And particularly a shout out to all the folks from Alberta. Alberta is somewhere that in the previous public health agency funded surveys in the country had never been a part of. And so for us to be able to go and do this work really for the first time in terms of doing a biobehavioral survey was huge. So hopefully we'll continue to fill in those gaps. We know there's lots of places we didn't get to, and so that's something that we'll work on in the future. We had a pretty good age range in terms of the study, and in terms of ethno-racial identities, one of the criticisms or critiques that we've gotten over the years is how white our online samples can be. And so it was really nice to see that we had a lot more ethno-racial diversity in the in-person survey. I think despite thinking about the politics that are highly important in terms of the barriers that are created for folks from certain communities to participate in Pride, we nonetheless had still a pretty good distribution of diversity on these kinds of categories. And particularly, I think Harlan and other folks who helped us with Indigenous recruitment should be quite proud of that 9%. And just to re-echo, I think what Jody mentioned briefly is that we don't see this as oversampling. I think that concept can be problematic. I really see this as a piece of trying to make sure that we get enough data to say something meaningful about these communities within our broader community. And we know that we've got work based on these percentages to do with other communities as well. In terms of sexual identity, we had gay men out loud and strong, but we also had a strong percentage of bi guys, queer guys, pansexuals, and 1% who reported being asexual. And then in terms of gender, this was also somewhere where I think we did a lot of work in consultation in advance of the survey to try and make sure that the questions we were asking would make sense for people of different gender identities and different bodies. And so I was really proud to see this kind of turnout. I also think this reflects very strongly the politics that are still embedded in a lot of Pride festivals across Canada right now, where a lot of the fight has been around issues around gender. And so to have this kind of response in the survey is great. I'm also really excited for folks, if you haven't met already, but Leo Rutherford will be doing a fellowship with us over the next 6 months to specifically lead some consultations and analysis around trans and non-binary folks in the survey. I was also super excited. How many people saw the Investigator's presentation yesterday afternoon? I know you had lots of great choices, but really excited to see the kind of interest and engagement already in those programs with some of these data. So yeah, really excited about that. In terms of relationship status, about half of guys were in a relationship, and we asked folks about the sexual agreements they had within their relationships, and about half of those in a relationship said their relationship was closed. Quite a few said it was open, 40%. 5% of guys said they don't know or hadn't talked about it, and a few guys reported not having sex with their partner. And then when we asked about partner's gender, this was also somewhere that we start to think about. So often when we think about inclusion, we think a lot about just thinking about the person who's doing the survey. But one of the things that that often does is that it assumes then that they're only having cis partners or they're only having joint partners of a particular body. And so I think one of the things we've been trying to think a lot about is how can we create questions that really work for doing inclusion beyond just the person who's sitting in front of us filling out the survey. And so in terms of partnerships, we saw during the vast majority of folks were in a partnership with a man, but there were 7% of folks that were partnered with a woman, over 1% partnered with a non-binary person, and about 5% of folks in poly relationships with some various combination of genders. So as folks will likely know, we were funded in 2018 by Canadian Blood Services to run this survey. So a big part of the focus was about the blood deferral policy. And at that time when we were doing the survey, it was a 12-month deferral. So if you were a man who had any kind of sex with another man in the past 12 months, you were not eligible to donate blood. We asked folks a little bit about how much awareness they have about the blood donor system and deferral policy. And the fact that all donations are tested was known by about 2/3 of guys. About half knew, based on our HIV evidence, that men who have sex with men are 70 times more likely to get HIV. To me, this is an interesting piece because I do think it's something important for us to think about in terms of our HIV education work. It's not just necessarily relevant to the blood policy. Half of folks knew that the screening process of deferring people out was related to trying to reduce window period infections, so infections that might occur between the time when someone acquires an infection and when a test can pick it up. And we also really wanted to ask folks and prompt them about what was happening for our trans and non-binary peers in terms of the fact that Canadian Blood Services largely screens based on genitals, not based on gender identity. And so that was, not a lot of people were aware of that. And for me, when we think about these issues, particularly from an intersecting point of view, is that if we solve this problem or issue in terms of gay men's blood donation and leave behind a legacy that's bad for trans folks, then I think we've done an injustice. And so there's an opportunity here when both of those policies are being discussed for us to try and provide a solution that works for everybody. We also asked folks what their attitudes were, and this probably won't surprise people, but the vast majority of people felt like the policy was discriminatory, but a few people also felt like there was justification for it. And there's some good qualitative work that Daniel Grace and others in the country have led that look at that in a bit more nuance. And so you can talk to them or you can ask questions about it if you want. But I think really fundamentally this is a work in progress. So as folks will know, after the survey there was an announcement around a 3-month deferral. In terms of that, we found that 4 to 5 guys supported a shorter deferral period. And so now the question kind of lends itself to, well, are we happy with that and have we reached the end, or do we feel like there's more work to do? From an organizational point of view, I think we very much feel like that is not the solution of having an MSM-specific policy, and we're continuing to push for an individual-based or behavior-based gender-neutral approach. So that's where we're working. If folks read the Huffington Post, there was an article this week that we got published in relation to the summit around that as well. So next week we're going to Toronto, and all of the projects that have been funded by Canadian Blood Services on this issue are going to be meeting to talk about what information they've gathered so far and where we need to go in terms of moving forward on this. So that will be interesting. We also asked people about their support for alternatives, and that's really kind of like how can we create justifications for other processes. And so we asked people about whether if we asked about specific sex practices, or if they had a new sexual partner, or if they had a certain number of sexual partners, would those be acceptable alternatives for people in terms of being screened for blood donation? And we found pretty similarly not a lot of difference across those, that generally 4 to 5 guys supported those. 60% of guys supported any of those options, and were I think kind of telling us whatever it is, we don't care as long as it's not MSM specific, and 90% of guys supported at least one of those options. So quite a bit of positivity towards alternative solutions. And I think that really reflects also the future intentions piece. So we were able to look at the data and say, okay, so given that it's changed from 12 months to 3 months, that would add about 14% of the community into being able to donate now, meaning that those guys reported not having sex in the last 3 months. And so when we think about how many guys were interested in donating, this was a particularly positive response, during over 90% of guys saying that they would be willing to donate in the future if they were allowed to. And so we also wanted to look a little bit at behaviorally what might be some of those other opportunities for screening. And so we found half of guys had reported condomless anal sex in the past 3 months. 40% only had one partner. 40% had no new partner. And so there's quite a bit of opportunity here, I think, to increase the number of guys who could donate. And that is really twofold for me. It's not just about getting more guys to donate. It's about creating a system that people feel is justified and supported, because that ultimately contributes into the perception that we have a safe and sufficient blood supply that's available for people who need it. I think also really importantly, it's good for us to think about the fact that there are many people within our communities that are also relying on blood products. And so this isn't just an issue of us or them, but that these are intersecting issues. And so I think fundamentally we want to hold all of that together as we think forward in terms of a solution. So as I said, people had the option of getting a dry blood spot uptake. And we had a really positive response to this, higher than I actually thought we would. I don't think a lot of people go to Pride to get pricked and donate blood, but 87% of folks who participated did give us a DBS. We found that did vary, and it varied by site. Part of that relates to when we were in Winnipeg, there was also point-of-care testing that was happening on site right next door with our partner, our own health center. And so that was likely why we had a little bit of a lower uptake there. It was also our first site, so we were learning a little bit about doing this, and as high as 93% in Montreal. We also saw that there was less uptake of dried blood spot as an option for folks from African, Caribbean, and Black ethnicities, Indigenous folks, and South Asian participants. So to me, again, I think that's the kind of conversation we need to have about what could we do to try and make this a more appealing option? Are there other things we need to do in terms of messaging or information to really make sure this is accessible for everybody? And we didn't see a lot of other variation in terms of DBS uptake by age, identity, non-binary status, or trans experience. So we have not showed these results anywhere before, and so I'm really excited to get to share them with you. These are the biological results of the survey. So we tested for HIV first, and then hepatitis C if there was sufficient sample left. We then tested for it. So that's why we had a bit of a higher insufficient sample rate amongst the Hep C. So what that means basically is that we had just under 3,000 samples left to test for Hep C. So amongst those, the vast majority, 2,930, were not reactive for hepatitis C. 9 were reactive, meaning they would be an active infection of hepatitis C. So of all of the viable or sufficient samples, that's 0.3%, which is a very low number. Of those 9 that were reactive, 1 had reported never being diagnosed. So others had some kind of reporting in terms of having been diagnosed, being actively in treatment, or other similar kinds of things. So that's a really, really low fraction of folks unaware of Hep C infection within our community. When we switched to look at this in terms of HIV, we had a much lower number of insufficient quantity, as I said, because we tested for our HIV first. That was our primary test. And in terms of reactives, we had 2,951 that were non-reactive. That's 96 or 97% of the DBSs that we tested, and 102 DBS results that were reactive. So that would be 3.3% of the DBS samples that we tested. So when we think about those 102 reactives, 99 of them were folks that had said they were already aware of their HIV infection. And so of those other 3, 1 had said they had never been tested for HIV, and 2 had said they had never been diagnosed. So for us, that's 3 guys in the sample that were unaware of their infection. And so when we think about that from a kind of like public health point of view, we often talk about that as the undiagnosed fraction. So when we look at the overall survey respondents, and we know there were a lot of PAS guys who didn't provide a DBS because they're like, well, I already know my status, so I don't need to do this. There were 234 survey participants who said they were previously diagnosed with HIV, and then we add those 3 who were unaware, so that's our kind of denominator, and that leads to an undiagnosed fraction of about 1.3%. This is a lot lower than other estimates that we've had in the country, and so I think there's quite a good conversation for us to have about, is that related to where we went and who we talked to? To me, I think generally my overall summary around this is that these are probably the most the best case scenario results that we could think of for the community. And so we're going to Pride where people are doing out at Pride and they're participating in a survey. So I think that's important that it gives us the best case scenario, but I think that's also an important qualifier for it. So when we think about the overall study sample, that's 0.1% of all guys having HIV as an unaware infection. So happy to talk more about that, but wanted to give you folks those results. And I think we're going to need to unpack these results over the coming months with folks in the community as well. One thing that was new for us this year with the survey is that we also wanted to give folks the option to get their results back. That was important because previous surveys had not given people that option, and we were very much of the opinion that people had the right to their body and the information that we have on them as well. So we created this non-nominal, meaning they didn't have to give their name, peer-based referral process to give people that information back. A lot more people asked for that than we also suspected, and so about 70% of people requested results. Of those that were not known to have an infection, whether that was Hep C or HIV, about half requested results for those. And we successfully reached about half of people. And so some people might see that as like, well, you also didn't reach half of those other people. And some of that was related to, we learned that having people write their phone number or their email on a piece of paper with a pen was not the most legible form of collecting that information. So we'll fix that for the future when we do that. The other piece is that for some people, we passed information on and they didn't necessarily recontact our team. And that, again, is their prerogative, and that's important for us from an ethics point of view, that they're engaging how they want to. But I think fundamentally for us, we also return information to doing half of who we could have, but it's half more than we did ever before. And so fundamentally, to me, that's important in that we did this, and before there was nothing. So we're also doing a bit of an evaluation, both looking at some of the quant data, but also doing qualitative interviews around this process. And so we'll learn a little bit more about what we could do better in the future around that. So Sex Now is more than blood donation, as are our lives. So we also ask people about prevention knowledge, and what do you know about condoms, PrEP, U equals U. And we see fairly high levels of awareness around these kinds of things. We also ask people about PrEP use and interest and barriers. So I'm going to take people through this chart a little bit because it's not super clear. But if you look at the top left, the lightest shaded section, about a quarter of people had never used PrEP and were not interested in it. And then if we go around counterclockwise, another quarter of people had never used it but were unsure if they wanted it. About 20% of people never used it but wanted more information before deciding if they were going to use it or not. About 13% of negative guys in the survey were using PrEP at the time of survey. And 13% of guys said they never used it and they wanted it right now. So for me, when I look at those last two sections, basically half of who wants to be using PrEP at that moment had access to it. We know a lot of things have shifted, both in terms of policy and in terms of services, and so it will be good for us to reevaluate how well some of those changes in some provinces or some cities have had in terms of making an impact on this gap. We asked guys about what was stopping them from using PrEP. The top reason was that a third of folks said they didn't feel like they'll get HIV. Cost was the second most common barrier, followed by side effects, not liking pills, not having STI protection, not being able to get a prescription, and the last two being judgment by a doctor or by guys in the community themselves. So some of these we know that we can address more readily through policy and health service revision, and others I think are work that we need to do in terms of community health promotion. We also ask about general healthcare access and barriers. About 3 to 4 guys said they had a regular family doctor or nurse practitioner, and about 80% of those had told them that they have sex with men. We also asked people if they had been denied services, and so we see pretty low percentages of folks reporting having been explicitly denied after asking for an HIV test, PrEP, or PEP, but nonetheless I still think that this is a metric that really should be zero, particularly in the context of post-exposure prophylaxis. We also asked around gender-affirming surgeries and hormone therapies, and so when we look amongst trans and non-binary respondents, we see much higher percentages of folks in those communities being denied those services after asking for them. I think that ties very closely onto the conversation that Erica talked about yesterday on the panel. We also ask about mental health support and violence. So these are things that people said they wanted help with: anxiety, depression, body image, relationship problems, suicidal thoughts, eating disorders, coming out. Gender dysphoria and transition also being about a third of trans and non-binary respondents asking for more help around that. We used for the first time some psychometrically supported scales in terms of screening for anxiety and depression, these brief 2-item measures that are really just an initial screen. And so we found that 1 out of 5 guys had potential issues around anxiety, and about 1 in 7 in terms of depression. In terms of intimate partner violence, this was abuse in the verbal, physical, or sexual realm from an intimate partner. And we found about a quarter of guys reported verbal, 1 in 7 physical, and about 1 in 10 sexual. We also asked about forced sex, both as a child or as an adult, and found that about 20% of people reported forced sex as an adult and 15% as a child. I think it's important that our communities have conversation, given the women and feminist movements around Me Too, that we really talk about this issue of sexual harassment, sexual assault, and sexual consent cultures in our community. On the social support and satisfaction side, about half of people are engaged in some kind of social activity, whether that be activism, volunteer, participating in queer pop-ups, or political work. I think that really reflects our community's engagement and activity in the broader society. We found that this is a survey at Pride where people showed up to a community event, and 3.5% said they had no one to count on for support, and a further 4% said they only have one person. I think that's still surprising to me, at least. We also asked about satisfaction with physical spaces to meet guys and connections to gay men. And so there was also, I think, a much better analysis of this done by the investigators in Edmonton. So hopefully you saw their talk or their poster yesterday. And we also asked people at the last question of the survey is, what sex do you enjoy the most? Remember, this also is about the sex we have and the sex we want. And surprising or not, you can all just have some personal reflections of whether you think giving head is the most enjoyable sex act or not, but that was what we found across the country, at least at Pride. So if you're making Pride plans for next year, you can take all of this into account. So that's kind of our Sex Now 2018 take. For us, one of the most exciting things I think that's come out of the program has been this RStats data visualization dashboard. Really functionally what that is a website. So you can go to it, it's live now, it's called ourstats.ca. That's our, O-U-R, stats.ca. And what it really shows is the ability to look at the data from 2015 and 2018 across the different provinces in Canada. And there's a toolbar on the left-hand side where you can pick what variables or questions you want to look at. If you want to divide that up amongst folks based on HIV status or ethno-racial identity or trans experience, whether you want to look at particular provinces or the whole country, whether you want to look at a subset of the community in terms of maybe I want to look at just young guys. And so this is a tool that we're hoping people will give us some feedback on. Kiffer and his team have done a lot of work to put it together. He's going to be running a workshop later this morning, which is in your program. So if you're really interested in this, we're hoping that it'll be something that's quite helpful for people who are writing grants or doing program evaluation or doing health promotion campaigns to be able to quickly draw some statistics and numbers for those kinds of projects that you're doing in a way that gets us out of the way and lets you do it directly. So if you've got questions or are interested in that, I haven't seen Kiffer this. Oh, Kiffer's right here. So Kiffer's right here. You can give a little wave, and you can talk to Kiffer or go to his workshop. So in terms of getting more involved, if you've been so inspired by my talk this morning, then we do data sharing agreements around the data, and we'd be happy to talk with you if you're interested in having access to the data. These are relational processes, and so we look forward to having a conversation if you're keen. Our 2018 data is ready. There's a number of folks across the country that have it already, and our 2019 data will be ready in 2020. Also, if you want, you can join an Investigators program, which is rapidly expanding across the country. I heard Brooke committed to a new one last night as well. So there's just new sites all over. So that's one option. Otherwise, if you're a graduate student or a student that wants to use this for a practica or a thesis, we'd also be happy to talk with you about that. We want these data to be used. That's really why we collect them. That's fundamentally the ultimate goal. So, Sex Now 2019 online. It is officially online. So, yeah, it happens. This photo is a bit dated, but I just love using it because there's a funny story behind it, which I don't really have time to talk about, but also because like Todd, for example, is like holding that, and Todd's been someone who's been involved in CBRC for a number of years and continues to be. But I think also what's important for me about this is that it really, for me, shows this balance between in-person and online, and that we need to be in person and we need to be online, and I think we've learned that there's quite a bit of different information and different connections that we get from both, and so this is really an important piece in terms of our balanced research approach. So please take the time to do the survey. We'll be doing some more formal pushing out of it in terms of promotion over the coming days and weeks, but we wanted to get people through Summit before we totally tried to take that over. But the goal will be to get as many people as we can to do that before the end of the year. The other thing around 2019 that I wanted to talk about is there's a bunch of new questions. So one of the nice things about online is it makes it a bit easier to add more questions, partly because for lots of different reasons, but we've got questions about gender experience, more questions about migration and immigration experience. Those came really from the Toronto Investigators program. Questions about sex education, about STI, pre-exposure prophylaxis, about disability, about sexual orientation and gender identity change efforts, motivations for substance use, comfort in spaces and safety in spaces within our community, service accessibility, and impact of sexual orientation on our well-being and lives, just to name a few. So it is an online anonymous survey, and we have a $500 travel voucher, which you could use to come to Summit next year if you wanted, or go anywhere else. And one of the other things that we're doing in terms of innovation on this is allowing folks who are in BC to opt into an at-home DBS collection. What that means functionally is that if you're a BC participant, you'll have the option to basically opt into us mailing you a kit where you can collect your own DBS sample. It'll be shipped to you via Purolator, and then it'll get shipped back to our CBRC offices, and then we'll ship them on to the lab for testing, and then we'll return them in the similar way that we did to the 2018 For us, I think this is really important because we know that access to testing in particular is a very geographic issue, and so the opportunity to give folks this chance to learn about their status and try out this DBS process in all of the different parts of the province, I think we're super excited about. And there's a panel next that Mark Gilbert is moderating around testing innovation, so if you're keen on that particular part, then I'd say go to that. The other thing that I'm very excited about to announce is that we recently signed, as of last week I think, a contract with the Public Health Agency of Canada to deliver a new national survey inline in 2020. So that contract outlines that we will recruit 4,000 participants at Pride festivals next year, and we'll go to 12 to 17 different cities, so hopefully we'll be able to add in some of those geographic gaps that we had in 2018. And we'll also move to electronic survey collection via tablets. For any of the investigators or people who are involved in manual data entry and checking, you'll probably be quite relieved about that. Some new innovations, but I think for me what's really important about this is the Public Health Agency really naming CBRC as an organization and a collective in terms of all of our community partnerships that can deliver their national biobehavioral surveillance program. I think that is a huge move from previously this being administered through either provincial governments or through health authorities. Fundamentally, this is a relationship between us as the community and Her Majesty the Queen. And I like that. So it's not without its challenges and issues, but I think it's a super exciting time in development. The other thing that we'll look at in terms of this is that through the contract, we didn't want to have people's contact information going to PHAC. And so because of the way the contract process works, we're not going to return results from the dried blood spots. And so we're instead going to continue to do what CBRC has done for since its inception, and is to innovate. And so one of the things that we're keen to try and bring, as folks will know, we have no oral point of care test available in this country, and that may be an option for us to look at providing in the Pride setting to get feedback about how guys feel about using that as a potential option. And fundamentally trying to bring some additional support to bringing new tests and options to market here in Canada. So this is all pretty early days on this. As I said, we just signed this recently. And so we'll have a process of consultation across the country in terms of the survey and these options around testing and specimen collection. The other piece in terms of next steps is around the online survey. And so we hope to be able to expand that mail home process nationally and really thinking about how we can create bilingual results lines for linkage. I think there's a lot of opportunities here for us to act and develop what a low barrier service could be that helps to try and buffer between sorry. I was like, that's why I was holding on to the edge. I was like, between the community and public health. So with that, I'd like to thank all of our participants, past, present, and future, all of the community partners in the Advance Avancé Alliance, all of our staff, Rob and Ben in particular, who have been the managers for this project, and the hundreds of volunteers across the country that take time to make this possible. Our research working group members who are kind of our guiding rudder, our core team that meets weekly to make all of this happen, and the folks that contribute to our grant teams to help make sure the resources are there to make this possible, as well as our collaborators and funders. So thank you very much. So, as I promised, there's some time for questions, but one thing about questions that I'd like to just offer, and we do this at one of the other conferences that I go to, is that if you're a first-time attendee or a student, then we will give you priority at the microphone. So, newcomer's prerogative. So, are there any questions or comments that people would like to share? And if you're a first-time attendee or a student, we would like to see you at the microphone. They say to wait 20 seconds, which is a painful amount of time, but I'll wait.
So I had a question about the anxiety and depression data. Were you shocked by those values? Because in my personal community, it seems like it's should be a lot higher. I know it's anecdotal, but that's just what I was thinking.
Yeah, I think I wasn't totally shocked. I think, one, it's the first time we've used those screening measures for that. I'm not a mental health provider or professional in any sense, so I'll just name that. And so from talking with folks, there's many different kinds of anxiety, right? And so it's a generalized anxiety screen. I think the other piece for me too is who we talk to, right? So if we think a little bit about folks that might be struggling with mental health challenges, Pride space might not be a space that necessarily participate in as much. So again, as I kind of said around the biologicals, I think this is kind of the best case scenario in many ways for our communities. And so, yeah, I mean, we can drill down a little bit more. What I'm interested in looking at in the future is doing how do folks who articulate wanting help with anxiety and depression, who aren't meeting those criteria for screening, doing where is that gap happening? Because those screening tools are a part of a more clinical world, right? But we have guys who are telling us that they want support for their anxiety and depression. So I think that gap is where the important piece lies, I guess.
Thanks.
Yeah, thank you. Good morning, Moonbat.
Hi, Nathan, how are you? Your data around donating blood as a result for those who have tested for STI, I'm wondering if there could be an argument made that that should be used as a screen rather than who you are?
Yeah, so I think, so there's a lot of different potential options in terms of potential screening. And I think the ultimate goal, of course, is to not end up with an infection in the blood system. I think given the history of what's happened in this country and other parts of the world, that's the ultimate driver, is the blood supply. And that's related to the fact that people who are relying on blood products are prioritized. So in terms of other options, I think one of the things that we need to try and show is that whatever tool we're using, whether it's a single question or multiple questions, is that that's going to be a robust metric of safety, for lack of a better term. And so in terms of STI testing, I think we know those are really high numbers, but STI testing doesn't always include HIV testing. It doesn't always include Hep C testing. And most of the other STIs aren't necessarily of, HIV and Hep C would be the two that are of greater concern in the blood supply. So yes and no, I guess, is kind of my answer a little bit, if that makes sense. But it's definitely something that we've talked about in terms of the overall conversation. Yeah.
Hi.
Hi, Rick.
Congratulations on just a great effort. And you really covered so much of the country. One of the areas that we tried in the past to reach people is in the north. And I wonder, did you get any data from the north this time? And do you have any plans to,
Yeah, it's a good question. So in the online survey, we had a few people who said they lived in the territories. And that could be accurate, or that could be people being cheeky. I'm not sure. But there's really quite a few, like very few of them. I think with the online survey in 2019, I'm hoping that we'll have a bit more response from there. But in terms of the in-person, we didn't get a lot. I'm hoping that maybe through 2020 we might be able to try and go to a Pride in one of the territories.
I was going to say that one thing I learned was that Iqaluit has a Pride. So, when is it, and could that be one of the sites?
Yeah, so I feel like we should take a sign-up list for like which prides in Canada would people like to go to, and to bring our tablets. Because fundamentally, this is really built on like people being willing to partner, right? And so, as we started out our survey last year or in 2018, there were a number of places like Moncton, for example, came and was like, we would really like to do this, and so we were trying to, yeah. And so I think, like, for me, I think what we need to do is, now that we have the contract signed, I think what we need to do is tell people that we have this opportunity and start those conversations about who is interested in doing this, what do people need to make that happen, and so that's going to kind of be our process next. And to me, the more places we can go, the better. I don't think we actually have to cap out at 17. We just have a limited resource pool to do it, right? So I think it would be great if we could go.
Yeah. Is it possible, or is it ethical, well, ethical, maybe not the word, but to skip out on a city that you've been doing many times and that there would be data for maybe in 2018, but then not do it in 2020 so you can do a city that you haven't done before? So, sadly, some cities might have older data than other cities, but that way you can, depending on your resources, get to more places.
Yeah, that's a great comment. I think, and to be honest, I think PHAC was quite interested in the fact that we had done data collection in places that it hadn't been done before. The fact that Calgary and Edmonton had never been done, it was wild to me. And so I think, and there's lots of other places. I mean, when we look at Atlantic Canada, the only place we went was Halifax. And we know that's a huge geographic region that has a number of different provinces that have a number of different provincial policies and systems. And so I think if we actually want to support folks working in the Atlantic to be able to compare and contrast what's going on there, then I think we do have to go to other places. I'm not going to commit to saying no to anywhere right now, but I do think your piece is a good one in terms of thinking about, as we have that conversation about where we can go, is not necessarily just prioritizing our biggest major centers. So, yeah. And that might be just a little bit of thinking about maybe we need to resource more some of those new places, and yeah, we'll consider that. But if you've got ideas of who you want to cut, you can tell me privately. Oh.
Hello. I just have a question about like the DBS you did during the Pride. And like when you do that, do you have like counselor or like psychologists to help like the people unaware of it? Because I still think about the 3% you talk about, and I'm like a bit shocked for them. Like they were like party and WhatsApp and. So
yeah, great question. So you're asking a little bit about what kind of supports were available for people in doing this process. Yeah, so one thing that was nice about DBS in some ways is that it's not an immediate result. So when we're doing the collection, it's just collecting folks' blood, which then gets put onto a card that then has to go to a lab and get tested, and that takes a lot of time. So I think one thing that we need to think about is if we're going to do something that's point of care, then we need to have a very different system in place. And so if we're going to do something where people are going to get their result immediately, then that is going to be quite different. We have some experience in terms of that, like in Winnipeg, where our partner was providing rapid point of care testing. And so they had health professionals that were on site as a part of that, and a referral process if things happened, where people would need support. And so I do think that's kind of, for me, there's a bit of divide there. The other piece more broadly about doing DBS in the Pride setting is it was a bit experimental for us in terms of whether that would work. In the past, DBS has been collected in bars, in bathhouses, doing it at community agencies, and so we felt like Pride would work. It's a pretty high volume, busy, hectic space, and so we tried to make sure that people had the time to get their questions answered and to do that. And to me, I think the vast majority of people were really happy to do that. And so it went better than I thought it would, to be honest. But I do think, as you raise, if we're going to be giving people information back about themselves in that moment, I think we're going to need to think a little bit differently about our consent process and about our support process. So yeah. And if you've got ideas about that, let us know. Oh, okay. Yeah, sorry. Time's up. Thank you, everybody.
Yeah, so I think we're just going to move right into our concurrent session. So the hotel staff will be dividing up this room. I think we're mostly on schedule, so we'll try and proceed without any changes at this point in time. So thanks.
Is it morning break?
No. Yeah. That's what I know.